Our next session is the new frontier of immersion technologies in interprofessional education. And it's my pleasure to introduce to you Bethany Cieslowski. She's an associate professor in the School of Nursing in our College of Public Health. Andrea Landis, who's an associate professor in the School of Nursing. And Corbin Rickerby, he's the immersive technology specialist for the College of Public Health University. So please welcome this group of panelists.
Well, hello. Thank you so much for having us here. Bob introduced us. I will tell you, I've been working in simulation for a while now, last probably 10 or 12 years. And I always start my talk and go right into all the business that we're doing and the exciting stuff, but I'm actually going to slow it down today and actually talk a little bit more about what simulation is, how it's defined, and who else here is using it. So we're going to talk about the landscape of XR. We're going to talk about our interprofessional cases, what we're doing at the college. We'll talk about AI integrated platforms, and Corbin will talk a little bit about that more specifically. And then we'll talk about future directions. So before we get started, what is healthcare simulation? Is anyone in here using simulation at your university or in your practice setting? Yes? Well, I know you guys. I know you're using it. And no one from Mason can answer that. No, actually, it's a test. Anyone else from other institutions using simulation? Yes? No? No. Okay, so we'll talk about it. So I usually skip this part, and then I do the whole presentation, and someone says, hey, Bethany, what's simulation? I realize I've missed the opportunity. So it's just a recreation of clinical scenarios that enable people to practice. In our case, it's students. It can be used formative or summatively. We mostly use it at the college formatively. We use it as a tool just to learn. And we'll talk about how we do it at the college a little bit more specifically. It's really the foundation for safety, advocacy, and leadership. So those are the three tenets that really focus with simulation. We are all certified at the College of Public Health, and we'll talk about that. We actually have the college accredited through SSH, so we're the only College of Public Health, or the first College of Public Health with SSH accreditation. And we'll talk more specifically. These are our certified healthcare simulation educators. So they've all taken a test, and this is how we implement simulation for our students. I'm the fifth one. We also have a simulation technology specialist. Now, this is somebody who really are the brains behind the applications we use. And we also have an immersive technology specialist, which is Corbin. And he came to us with a lot of game development in his background and has really stepped into the educational space and taken us to the next level. So we're probably the only university or college that has someone like Corbin working within their simulation lab. This is me. I led the team. But what's really important about this slide is that it's really innovation enabled by technology. Even though we're using all these different types of technology, the innovation is really the outcome that we get with our students and the learning outcomes. Andrea was going to talk a little bit about the healthcare standards of best practice. All of this is evidence-based. So everything that we do, and I think I drive everybody crazy at the college because I'm always like, it has to be high-quality simulation. It has to be evidence-based. But what's important about that is that every simulation starts with a pre-briefing. And a pre-briefing is probably one of the most important pieces, which you come in, we orient our users. We talk about a safe learning environment. We get the technology out, the hand controls and the headsets, and we explain how that's going to work. Facilitation and professional integrity kind of go together. That's where the simulation itself happens. And then most call the debrief the most integral part of the experience. So here you see, this is the time frame around like each of those components. The pre-brief can be 15 to 30 minutes. What's interesting about this, it depends on the case that we're doing. So it could be opioid abuse. That's affected a lot of people. Or we might be talking about mental health issues and suicidal ideations, and that can really hit people at home. So a pre-brief for that might last quite a bit longer to prepare our learners for what they're going to experience and to know that in the simulation, we're intentionally kind of traumatizing people with an experience that's not real. And so they can trigger quite a bit of students and faculty or anyone participating. So we might take a little bit longer there. Everyone always thinks simulation or the virtual reality component is it, right? And it's actually only 15 to 20 minutes to 30 minutes, depending of the experience. And the debrief is usually twice as long, usually. And again, it depends on the topic. And this is where you have your theory bursts and your teaching moments. I always say this is the most important part of what we do. It's the basic assumption. This lays the foundation for a safe learning environment. And it's that we believe everyone participating in activities at the George Mason College of Public Health is intelligent, capable, cares about doing their best, and wants to improve. Why is this so important? Because you can go in there, and I've had students say, I didn't know what to do next, right? So they're simulating, they're being watched, they're performing, their professional integrity is on the table. Graduate learners, even higher, right? Even harder the fall if they make a mistake. We've all been trained in a method called, or approach called, debriefing with good judgment. And this is at the Center for Medical Simulation in Boston. This is me debriefing a group. We're always in a circle. I don't have a white coat on. No one calls me doctor in there. And it's because you want to level the playing field. So if a student makes a mistake or a colleague makes a mistake, you want to talk freely about it, and you want to make sure there's as little judgment. There's never no judgment as possible. So that's how we simulate, that's how we debrief. Anything you want to add to that?
Do you want to give them an example of?
Debriefing with good judgment?
Yeah, what you usually do with me a lot.
So typically we could go in, we might have a student do safe medication administration, and Andrea might come in and administer 10 milligrams of morphine. And if I'm watching that, debriefing with good judgment always starts with a direct observation or example. I'll say, Andrea, I saw you go in there, I saw you push 10 milligrams of morphine. That concerns me, right? Because the order was for 1 milligram, 10 times the amount. But I'm wondering what was going on in your brain at the time. And so it gives you a concrete example of what happened, the mistake that was made. I'm the expert, right? I'm the instructor watching, my impression of that. But really, what were you thinking? Because frequently we'll just go into teaching, you know, the safe medication administration. And the truth is, the student will just say, I was nervous, Bethany. That's a totally different feedback session that's going to come after that. So it's like a privilege because it's very conversational in the way we just had it. And Andrea will typically just say, hey, I was nervous. And I'll say, okay, take a deep breath and move on. You know, we'll talk about those examples of how we process through that. Anything else? Good. The landscape of XR. That's another assumption I make. Does everyone know what XR is? And I'll go talking about what is extended reality. So I broke it down more specifically with you. So extended reality is just an umbrella term that's the full reality virtuality continuum. I love that. So I'm going to let Corbin talk a little bit about that. Do you have headsets up here?
Yeah.
Okay, so we can just show you also.
So over time, we've moved from virtual reality, which was our initial, put a goggles on your head, maybe 2016 that started to come about. And then we moved to augmented reality, where you're using your phone, projecting things in front of you and the environment around you. And now we're moving into mixed reality. I have a Vision Pro here. I'm sure you guys have heard of it, the Apple headset. Very expensive, but this headset will blend the environment around you into the virtual environment together. So those are kind of our three modalities here. We have augmented reality, where we're projecting stuff into our real space. We have virtual reality, where we're completely replacing the space around us. And then we have mixed reality, where we're kind of blending the two together and creating a new environment within the space around you. And the benefit of that is that you can see what's going on. You can perform actions with the headset on. For example, one that I always like to talk about that I would love to see in the future is perhaps inserting an IV with a headset on, getting prompts in the air around you, telling you, instructing you how to continue with that. So those are kind of our three modalities.
Excellent. Why have we moved from certain simulation or your typical simulation modalities like high fidelity mannequins or standardized patients, which are just actors that we've hired to train and act like patients or a family member. Why did we move to XR? Well, I would say our dean had a lot of foresight, and during COVID, they noticed that there's got to be a better way of doing this, so you can do it remotely. But also because clinical access, nursing has been using simulation probably longer than any other discipline, besides medicine, dentistry, things of that nature. And it's a struggle to get certain placements, and during COVID, we all learned that pediatrics and specialty placements like OB, mental health, very hard to get into. So for pediatrics, after COVID, when I came there, we had all these cases, and I thought, let's just give this a try. Let's use virtual reality and give our students, I think we did 12 hours of virtual reality, which is quite a bit in hindsight. And then we put students in the clinical spaces. And after the first group went through, we measured performance, and we did a standard mannequin-based simulation to see how they performed. And the virtual reality group performed better in almost every domain than the students in the hospital. So I only did that to kind of prove to my colleagues that virtual reality could work or might work, and the results were pretty astounding. Having said that, in pediatrics in the hospital, there's not a ton, students don't really get a lot of practice. No one really wants students of any discipline touching the babies, the adolescents, and things of that nature. But nonetheless, it gave us some insight to the power of virtual reality. It's so scalable. So for anyone who's ever worked in simulation, the setup, the amount of simulation operations specialists that you need, the instructors, everything, it can be very demanding. For this, we just hit a reset button, or a student can go through with a virtual reality headset on and say, hey, I didn't do very well, Bethany. You think I could do that again? And we're like, sure, that's pretty easy. And we can hit a lot of students. We actually, when we got certified, or accredited, when they came through, they were like, how did you get through this many students? And I said, we did it because we can just turn and burn, and everybody can get the same experience with the same scenarios. So that was pretty impressive. Again, safe environment, that's pretty much with all simulation. But we noticed students retained more, again, performed well, and then were able to practice more of the critical thinking, clinical judgment, and clinical reasoning. I will also say that it's of the highest fidelity. So I've worked with standardized patients, which people would say is really the highest, because you have an actor there and you can ask questions. With the AI integrated virtual reality, to me, it far surpasses that, because you're not having to train the actors. If there's an aggression, we do a workplace violence scenario, you can't really have an actor get too close to a student or even a colleague, right? But in virtual reality, you can actually have someone approach like this, and you'll watch people, they step back, and you don't want to make them so scared, but you want them to make them understand that it's more threatening than what you can really do with standardized patients. Oh yeah, and Gen Z learners love it. Okay, so like every year, we'll have freshmen come in. It's like they were born with the headset, right? And then our seniors are less familiar. But we also have a lot of non-traditional learners that are dying to get in the headset. So a lot of our CHASY certified educators are they're, how do I say this? Generationally, they're not like our students. But they will watch and want to get in that headset so badly. So even our non-traditional learners find it pretty fascinating. So what are the challenges? I kind of alluded to this earlier. Cognitive load, it's the mental effort needed to understand and carry out tasks. And then, of course, that's affected by how complicated that task is, by the student or the participant's prior knowledge and experience. How much is too much? So probably 12 hours when we first started. That might have been a bit much. But that's really always the question. What's great about extended reality or virtual reality is because you're doing a lot, you're immersed, and you have the audio visual, you can focus on kind of observing versus just that didactic and reading of text. Cyber sickness, with these new iterations of headsets, you don't even really see it anymore. Maybe out of 100 students, two? I'm just kind of anecdotally speaking, not necessarily giving you exact numbers. There's a lot less now with a headset that costs what? $500. So, I mean, that's a lot. Still, I'm not trying to minimize that, but still, you can get your hands on it. They can be a little bit uncomfortable. I would say the physical discomfort probably came more from augmented reality than it was the virtual reality headsets, disability. So this is the accessibility and disability piece. We actually had a social work student that came through that had some visual impairment. What were you going to say? And there are newer platforms and headsets that address the disability concerns or accessibility. And then, of course, cost. I don't want to minimize that, hardware and software, but as we mentioned, cost is coming down. I would say the onboarding is probably, I think people are more intimidated to get started. I don't know if you were in here earlier. I don't love to have to do a live demo in a new building where we're not sure, right, and have 10 minutes to try it. But he was able to do that in 5 minutes. So I have a 85 to 90% reliability that we're usually going to be able to do what we say we're going to do on a dime. I think that makes me feel very confident. Other modes of simulation do not occur like that. So I think the question we frequently get asked is, how do you get started, Bethany? So you got to have some upfront kind of money or grant money to buy the hardware. Software is actually pretty easy to adjust to, and then you got to have your team. So I think all of this doesn't really work unless you have an implementation team, and I think that's our biggest strength.
Hold on.
Go ahead.
I
Please.
think, Corbin has some experience with accessibility, or what he's seen or experienced.
So most headsets nowadays have accessibility features built in, which is extremely convenient. It's all built directly into the headset, so we can have the most amount of students push through as we can. Students with hearing impairments, visual impairments, there's things like screen readers built in, other visual cues that we can give. Some of the headsets will use AI to display subtitles in real time, so you can have a conversation with a person outside of the headset and see in real time updating subtitles directly in front of you and know exactly what they're saying. So those are kind of the two biggest ones that I've touched the most myself. There are obviously other things such as physical disabilities, not being able to walk. If, let's say, a student can't stand in VR, all of our cases can be done seated, which is awesome. There's movement around in the case, so you can interact with everything, no matter, it's fully accessible now.
Excellent. I also assume everybody knows what it looks like. So Andrea was like, could you put a few simpler images in? So this is essentially what we need to make this go. A laptop, and it used to be a gaming laptop, but we don't even need that kind of power anymore. The headset, the hand controls, and then we project everything onto a big screen. So typically we like small groups of 4, but sometimes we'll have 6 or 8, and in simulation, evidence says you can watch people simulate, and they get just as much out of it from watching as you can participating. So we usually project it. This is really the setup. You draw a play space, so it's very simple. And then this is our president coming in, and this is actually VR in action. So that's kind of how we do it. I always say it's not that impressive. You come into an empty room, and then this is how we do virtual reality.
Bethany, I just
Yes.
wanted to comment that thinking back to the accessibility, you might be thinking, well, wait, President Washington is standing up. He has to walk around the bedside. But actually, on the hand controls, there's a method of
Teleporting.
thank you,
Yep.
of teleporting to other areas in the room. So if you need to go over to a chair or go over to the other side of the room, you can just teleport using your hand control as opposed to getting up and walking in the sandbox or the play area. So that just kind of ties up that accessibility comment.
Excellent. So why do we do it? We had, Dean Perry had this vision. She said to me, build a center of excellence. We have a team that is wonderful and all Chazy educated, and we've deployed, or tried to deploy to offer VR to every student in the College of Public Health. And I'll tell you more about where we are with that. So I'll tell you a little bit about our interprofessional case library, virtual reality library. Not a very impressive slide. We started out with something called SimX. And SimX is very linear, and it's instructor-driven. You want to talk a little bit about this and the moderator?
SimX is our current platform that we've been using for a long time. It's tried and true. They have an excellent team. We've worked with them to create our own custom cases. It's very instructor-driven. Over the timeline of the case, the instructor drives the case using dialogue and actions that they control. The case is very linear because everything is pre-programmed directly into the case. We don't have something like AI steering the case like we would in our future platforms, which we're going to talk about later on. That's kind of the main limitation there, is we're relying on our instructors to run the entire case rather than focusing on our students, and that's something where we would love to see improvement in the future. SimX has its own platform for going through goals, and the way we write our cases defines exactly how the scenario should go. There are flow maps, so let's say a student does an incorrect action, it will take a different path down our flow chart and try and get to a different outcome. We have cases where the learner can either save the patient or the patient becomes unresponsive, and those are really powerful cases, but we do have those options within SimX. And then we'll move on to talk about some of our future platforms going forward.
And so I think that's a great example of where we have cases where students will perform. That's why the safe environment is so important, because they might end up, we put them into simulation and as a nurse, not even with an instructor. We just put them in as a nurse, and they're not yet graduated, or a social worker. They haven't yet graduated. So there's so much that's at risk there, so we want them to feel safe. And then in that scenario, we do have a case where a patient can go unresponsive. That has to be very objective driven, and we'll show you more about how we do that. So you have to be prepared. You have to prepare as part of the pre-brief that this is something that could happen, and then manage it from there. So these are 4 more recent, I guess we've done a lot more, but 4 more recent cases that we've built for the interprofessional interactions. One is a community crisis response. This is a great case. I'm also a psych mental health nurse practitioner, and so this talks about crisis intervention in the community, right? Everyone thinks like, how do you get to Dominion or the psych hospital? So this talks about like an 18-year-old or 17-year-old that's actually at a school having issues, and then the community crisis team comes and interacts with them. That's a very awesome experience for students. There's probably no other university that has a case like this that exposes their students to that. Not only is this for like nursing and social work, this also brings in our community. So we've actually had the police in and discussed and talked about this. We have a medication error and management and disclosure case. So our health administration, we heard that frequently they'll graduate and they haven't been in a patient room. So we wrote this case, and it's with nursing and health administration. And it starts out with a med error. So in simulation, it's hard to get somebody to make a mistake. So the mistakes happened at handover. And so it's really great for the health administration students to get to see this and then have to deal with the fallout of that. It's one of our greatest cases. I say that about all our cases. And then the effects of opioid abuse on children and family. This is a social work case. I see Emily's here and Holly, and we're gonna show you this one. And this one is a great case because it really hits home. Everyone's been affected at some point by opioid abuse, but very rarely do our students know how to handle and deal with that. So it's a great exposure. We've put social work and nursing together. The feedback on that case when they were together interprofessionally was unprecedented. They learned, we don't have as many social workers as nurses, so the ones that didn't get to have the social workers in there complain, because they really wanted to have that interaction. We have a nutrition in the NICU, which is having nutrition. As a nurse, I can tell you, if we're dealing with a premature baby and feeding, we would like to have a nutritionist in there to tell us exactly how that's going to go. So that's a new case. And then we just wanted to show you how we do this. When we develop a case, we start with learning objectives, and we very rarely veer off from this.
I just wanted, only because we are going to demo this case later, so we're going to just show you some of the learning objectives and then the kind of the introduction of the case at this point before we continue. So again, like Bethany was just saying, we usually start with the student learning objectives. So identify key community stakeholders and potential partners. Recognize the family's social support needs. Demonstrate engagement skills with the family in the immediate crisis situation. Implement appropriate risk assessment that would inform sequence of response to situation, and prioritize social services into the plan of care. And then the case that we will demo later is the opioid case. This is Jerome Marshall. So there's a description that's given as a pre-brief to the students. Faculty are aware of it, but it describes Jerome Marshall. He's a 19-year-old refugee from Uganda, lives in a high opioid abuse, impoverished neighborhood. His father is deceased, and his mother is remarried a middle-aged Caucasian man who struggles with an opioid addiction. Jerome has a younger half-sister, Namazi, aged 12. Namazi's biological father is not in their lives. Last month, the mother went back to Uganda to care for a dying mother and has been unable to return to the U.S. Jerome lives on his own, but is very close to his half-sister. Namazi told Jerome that her stepfather has been sleeping a lot and there isn't a lot of food in the house. At school, she has trouble concentrating because she's so hungry. Concerned, Jerome went to the home and saw that his stepfather needed some type of help. Not knowing what to do, Jerome took his stepfather to the ER.
So we just pre-briefed you, okay? There's a little bit more that goes in there, but that's like your basic pre-brief, and we'll play it at the end for you, and then maybe we'll go into a mini debrief depending on how much time we have. But you can already start to imagine the issues that are going to unfold, and then we'll just throw in there Namazi's voice. It's just, it immediately takes you to that place where you're like, ah, what are we going to do, right? Not enough food, and it's just amazing. All right, so let's get to probably why you guys are all here today, which is the AI integrated platforms. I just want to say we have two. We're using Lucid and Lumato. We are piloting these. We've probably had them for about 6 months, a little bit more. And so we are learning to trust these platforms more, and we'll show you examples of why we do and we don't. So you want to talk about Lumato and Involve XR?
So we're currently using two platforms. We're working with Lumato. They have a platform called Involve XR, which is a platform that we can use to design cases on the fly, change them whenever we would like. It's all AI driven, which makes it extremely expandable. It supports two different modes, which is a self-directed mode where a learner can stand in the headset, do everything themselves, and then the AI will infer what they said and their actions and create a report at the end, which we can come together and debrief with. Lumato is extremely useful to us because it's like a toolkit, right? Like they provide to us a bunch of tools to design cases ourselves rather than providing us with the cases as CIMEX does. So they're different platforms. They have their different strengths and weaknesses. Where Lumato really strives is on creating cases as quickly as we can and being able to change them and change the outcomes of those cases and how difficult those cases are, what audience do they cater to, that sort of thing.
And from a cost perspective, is very inexpensive compared to Lucid.
Yes, and that's
and other
primarily
platforms.
because they're not designing the cases for us, rather they're providing us the tools to design our cases ourselves.
Which is key, because you need someone like Corbin then to be able to do that.
And
Lucid
then we have
Reality?
Lucid Reality Labs, which is a developer that we work with. They are developing a platform with us called iXR, which is going to provide similar functionality, but not quite. With Lucid, we can create much more advanced cases that have a lot of turns, caveats, that sort of thing. We can create much, did I already say much more advanced? We can provide actions that we would like. The case can be driven exactly how we want it, as many steps, branches as we would like. We can even do things such as transitioning from different locations to others. Since we are developing it with Lucid in collaboration, we have so much more we have so many more options as to what we can do and provide for our learners.
And in this case, the first one with them that we're developing, we're using it for both formative and summative. It's the first time we're really doing it. So it'll teach the learner, but it will also then evaluate the learner at the end. So there'll be two different modes with that. You want to talk about the shared qualities?
Yeah, so the platforms are very similar in the fact that they both use AI. I can't really read the slide, I made my text too small. They both provide a multi-user networked VR interprofessional simulation. So if we would like to have multiple students working together in a room, we can do that. We can have one case where an instructor can be in the case, and then we can have up to 4, if not more, students working with that instructor fully in VR. That also opens up remote capabilities in the future. Not quite something we're looking into just yet, but we have talked about pilots here and there. Both of them utilize AI for their NPCs, powering them. NPCs being non-player characters, so your patient, let's say, or if there's a parent in the room with a patient or something like that. All of that is provided for us. I believe both of them use 11 labs for generating dialogue on the fly, so you can ask any question you would like, and you're likely to get a response that makes sense. They're all using GPTs that are specifically trained to work in these environments. They both provide real-time analytics and feedback. So that is one of the big key factors to opening up self-directed learning so that we can push through more students. They can all work on their own and come back together at the end. We can look at that performance data and see where a student went right, where they went wrong, and then we can have a discussion about that. That allows us, to have everyone work on their own, and then we can do that debrief at the end. So we can also, I mentioned before, remote learning. We can do that as well. We haven't super done a dive into that. I've done some research on it myself. I've, talked to people all over the world in VR, and you're able to see their body movements, that sort of thing. It's really amazing. And that can extend to learning, right? So we can have students all over the country learning together in one room in a hospital environment that looks extremely realistic and immersive. And they both have built-in debrief tools and session recordings, as we mentioned with the analytics and data. So the differences between the two are primarily that Lumetto is a toolkit for us to create our own scenarios, whereas Lucid is something that we're building from the ground up to do both that and create our own scenarios, working with the company to create something more advanced that we can, put a lot more effort into and make a lot larger cases. They're a lot more specific, so it's kind of like a blend between Lumetto and Simex, but they're still AI driven, so we can still have that AI interaction and talk to the voices, and they will respond directly. Both of them do not require any coding experience, but it requires prompting experience. So I'll show some of that at the end here. The big thing about Lumetto is that we have to operate within those toolkit limits, whereas Lucid, we can implement any GPTs or finer-grained responses that we would like.
And just from the provider perspective, Andrea and I can tell you that interviewing in history is one of the hardest things to realize. So when you have that interactive AI chat going on, conversation, you're startled when you're like, oh, what do I ask next? The timing of that is very real world. All right, this is just to brag a little bit. At Mason, we led this article with SSH, and so I'm just going to talk a little bit about the results of this in the next slides. I want to go a little quicker because I think we're running out of time and I want to get to the demo. What AI brings, we talked about this, the adaptive NPCs, which are non-player characters. Personalized learning, we talked about that, the analytics, natural language processing, which allows that conversational component. Accessibility, we talked more about that. And then, of course, this dynamic real-time adjustment, which allows for what you alluded to is this progression and scaffolding of curricula. Really neat stuff. Future directions. As we said, so in that article, we talked a lot about what, haptics. Haptics come and go in terms of where they are. For instance, in nursing, if you can't teach CPR using VR, right? Because there's nowhere to press and get the pressure on. We talked about the adaptability. Interprofessional simulation is probably one of the most challenging things to do, and where AI comes in or where virtual reality comes in is you can do it anywhere, like you just said, right? And you can all be in different locations. Trying to get schedules together is probably the most challenging part. We talked about the curricula and then the outcomes research. Again, I put Kirkpatrick's pyramid up there. It's always hard to get to. Does it change behaviors and does it give us the results, you know what I mean, in terms of the hospital? So we are in terms of just any kind of outcomes. And then I love this slide. This is from the AI Healthcare Simulation Collaborative. We talked a lot about the traditional IPE, which was with standardized patients, paper cases, trying to get people together. It wasn't scalable. And it really didn't mimic the unpredictable nature or complexity of real-world scenarios. I think we touched on how AI-enhanced and immersive technologies can really get in there and make it dynamic, scalable, and really show you these complex scenarios that students will interact with. Thank you. Let's get to the demo. And do you want to set it up real quick? Yeah. Okay. And any questions you have, I can do that while he's... So he's going to show Lumetto, and he wants you to know he's not a clinician, so it might not be clinically relevant. He just did a quick case to put together to show everybody what was going on. Just to show you the AI integration. Is it the mother in here, or there's a family member in here. You'll see that's like a non-player character that you can ask questions to. Okay. All right, you got this. What you need?
Just a
Microphone? I got you, don't worry. In virtual reality, he can't see anything else. He doesn't know all these people are watching, and we won't let you fall off the stage either.
Yeah, it makes it a little tricky to do up on the stage. But so this is Lumetto, our platform that we are transitioning to that has AI integration. I just walked very far away. Yeah.
We won't let him. Whoever said that, we won't let him.
Okay, so this platform will allow us to do stuff like, as you can see, we have a lesson in progress here that I started a while ago. So we get a checklist here that we're supposed to go through, and it will tell us sort of what we're doing. We can enable or disable this checklist as we go. I'm just going to quickly show off some of the conversational elements of this and how we can change it and how quickly we can actually change it. So I just got kicked out. So I can talk to this. In this platform, we can add as many NPCs as we would like. You can see our patient down here. His name's, I believe his name's David Roberts. And I can ask him that. So if I was unsure, hello, sir, how are you feeling today?
I've been better.
Is that playing audio? Can you hear it?
It didn't. He said, I've been better.
Okay, perfect. So he's not feeling super great today. Can you give me your name and date of birth, please?
My name is David Roberts. My date of birth is November 1st, 1975.
So I'm up here a little tall for some reason, but if I was able to check that wristband, I would be able to see his name and date of birth and cross-reference that with an EHR, which we have in this platform as well. We're going to continue to focus on the dialogue elements for now, but I can ask David. So, David, can you tell me your favorite food?
I guess I'd have to say pizza.
So
He says
David
pizza.
loves pizza. Can you tell me your favorite topping on pizza?
Pepperoni, definitely.
So because I can have this sort of, sorry, he's going to talk because I held the button down. So we can have this sort of conversation that's a lot more open-ended, and we can hit a lot more points throughout the case. So if I wanted to change this, for example, let's say we didn't want his favorite food to be pizza anymore. We wanted it to be steak or burgers or something like that. So I can hop out of this headset real quick, and I can show you the prompt. So here's the prompt. Let me lift that up just a little bit. So we require a bit of prompting. This is actually a fairly basic prompt and a fairly basic case. So I can put things in here. So if I were to ask him for example, his career, he would say he's a taxi driver. I can put in here his allergies. We can ask him his pain level, and I can code that in directly here. So when asked he'll report that the patient is having pain level 2 out of 10. So in the other case, I had said that under here that his favorite food is pizza. So if I come in here and I type, say burgers, and let's say he wants burgers. How do you like your burgers? Likes burgers with only ketchup. He's a little silly there. And no cheese. So we have a lot more information in here as well, but for now we're just going to save that, and we'll demo how quickly we can change these cases. So we could do a lot more with this. Let's say I have some time in between sessions. I can go in here and I can change the entire session to have a different outcome as quickly as I can type. And that is the beauty of using AI to drive this entire conversation. So if I save this here, I believe this one is the one we were just in. And let's also go ahead and change this. Let's make him a little older, just to have something more. We have a patient profile here, so I'm going to edit this as well. I'm going to make his birthday 1965. And there we go. Now it should be updated, so we're going to go back in the headset and reload the case. It's a little scary being up here in front of all you guys. I now know how our students feel. So we'll go back. We'll reload the case now. So self-directed learning. These are self-directed cases that I'm showing, by the way. I should have mentioned that before. I apologize. I believe it is this one. Okay, so we can start up the case again. Teleport over to him. Some of those accessibility features I talked about, I don't have a ton of room to move around on this stage up here, so I can teleport.
Ask any questions about the environment or controls as you proceed with the medication administration.
Thank you. Hi, David. How are we feeling today?
I've been better. I've been feeling pretty nauseous and dizzy lately.
So you can hear he's sort of changing what he says over time, too. Gives some dynamics to the case, makes it a little bit more immersive. David, can you tell me your favorite food?
I love burgers, but only with ketchup and no cheese.
And can you tell me your date of birth, please?
Sure, it's November 1st, 1965.
So before it was 1975, we changed that to 1965. So that's some of the beauty here, is that we can change these cases as fast as we'd like. And I can go ahead and end the lesson. And as you can see, I did nothing right and everything wrong. And at the end, we'll get a report of that as well, that we can come together and sort of show off. And I would like to show that real quick, and then we will end this demo. So if I come up here on a portal, sessions. So here's the one that we just did, 51 seconds wrong, and we only got a 16%, so not super great, but it gives us a log of every single thing that we've done in the case, every single dialogue that we say, and every action that we perform. And that's honestly just amazing to be able to come together at the end and have that conversation while we were all working asynchronously before. And that's just a quick overview of some of the capabilities of our upcoming platforms where we can, quickly change all of our cases.
We'll play for, I know it will over time, I apologize. We'll play a couple minutes in Namazi just so everyone can hear her voice from the opioid abuse case, and then you can exit.
Yes.
We did earlier.
Hello, Namazi. I would like to hear about what is going on for you at home and also at school.
Hi, I'm Namazi. Daniel's my stepdad. Jerome is my half-brother. My mom, Selma, has been in Uganda for the last 3 months taking care of my grandma.
I saw in your intake forms that you sometimes have difficulty concentrating at school, Namazi, and we also just heard from Jerome that he's a bit worried about you also. Can you share more about what your day is like?
I eat about twice a day, and usually it's a cup of noodles and cereal. I'm just not as interested in school as I used to be. My grades have been slipping lately. I feel pretty down and tired most of the time.
So that gives you an idea, just hearing her voice. I'm like, oh, you know. But, so we have multiple different applications that we use, and I'm sorry that we went over time. Thank you for coming.